I have the pleasure in inviting Professor Shackel to address us on his topic, liver disease, the good, the bad, and the ugly.
I thank the Royal Society for the opportunity to speak today. I'm going to talk about liver disease and many good aspects of what we've been able to do in the management of liver disease, the prevalence of disease, and where we could do significantly better. I do apologise as I can't be there today, as I had contracted coronavirus midweek and still in isolation. I'd like to acknowledge the people of the Kanamaluka, the traditional owners of the land on which we work, and we pay our respect to Aboriginal elders, past and present. We respect all Tasmanian Aboriginal people, their culture, and their rights as the first peoples of this land. I'm a current full-time employee of the Tasmanian Health Service based at LGH. I'm a university academic, and I've, over my career, held speaker and advisory roles to many pharmaceutical companies, some of which are relevant to the talk today. I'm also pleased to be a member of the research committee at the Clifford Craig Foundation and have received funding from this excellent organisation. As you may know from my title of my talk, I have a weak spot for spaghetti westerns, and it does summarise what we're going to talk about today. We're going to talk about some really outstanding achievements in medicine led by the development of hepatitis C treatment, which has revolutionised the care of hepatitis C. We're going to look at some fibrosis assessment, this concept of precision medicine, which I've been involved in developing over my career. We'll then look at the actual burden of liver disease, which will, I think, come as a surprise to a lot of people in the audience, and look at the effect this has had on the development of liver cancer and its incidence as a worldwide and local problem. Finally, we need to acknowledge some of the areas we need to do significantly better in. So by way of background, I need to explain to you what the liver does, where it is, and how it is damaged. The liver is a major metabolic organ within the body. It's our largest solid organ. It resides in the right upper aspect of our abdomen. It's our major metabolic organ. It also happens to detoxify most of the things from our environment we are exposed to. And it's the largest immune organ in our body as well. Life is not possible without your liver. The common agents that damage the liver are viral infection, which we're going to talk about, alcohol, fatty liver disease, autoimmune disease, and a range of other conditions. But those first four are the common ones that we encounter. Injury in the liver happens over decades, but irrespective of the cause, it follows a common path where inflammation leads to scarring in the liver. And that scarring or fibrosis tissue can result in a condition called cirrhosis, which is end-stage scarring, which can disrupt the normal liver architecture and is generally the precursor to the disastrous complications of liver failure or liver cancer. And one of the things we know about liver disease is that there is high amount of variability in such that two individuals exposed to the same insult, one may develop all these potential complications and another may not. And this means that we do need good, rapid, cheap, effective screening methods to look for people at risk of progression of liver injury. Now, this slide's not meant to bamboozle you, but to convince you that we've made significant progress in understanding the very molecules that control liver function and its response to disease. And this is very important because these advances made in basic laboratories will see changes in clinical practice with development of targeted therapies for liver disease. And I'll talk about precision medicine in a minute. So some of the things we've done very well. The first is the management of hepatitis C. So hepatitis C affects hundreds of thousands of Australians. This infection can become chronic in roughly 3/4 of individuals. And in a certain percentage of those develop this end-stage scarring. I've talked about cirrhosis. And in a certain percentage of those individuals develop the consequences of either liver failure and or liver cancer. And they can, of course, lead to death. Now, when you start with hundreds of thousands of people infected, even if only 10% of those individuals develop these complications, that's a significant health burden. In Australia, they're estimated to be annually between 600 and 700 deaths per annum attributable just hepatitis C. There are tens of thousands of individuals living with hepatitis C related cirrhosis and its complications every day in Australia. But this pales by comparison to what we see internationally. It's estimated between 400,000 and 500,000 people die annually globally due to hepatitis C alone. This is even less though than the leading cause, hepatitis B, which is estimated to be responsible between 600,000 and 1 million deaths annually. A major advance in medicine was made with the discovery of hepatitis C and then the development of very active, effective treatments that can target this and eliminate the virus. And this led to these individuals being awarded the Nobel Prize in 2020. And this, I would argue, is one of the true great success stories of modern medicine. What this research led to was the development of a range of agents with these unpronounceable names shown here, which are now taken in tablet form and can within weeks eradicate hepatitis C with great efficacy. Indeed, we are now so used at conferences to seeing figures like this that has now become commonplace. In patients given 8 weeks of therapy, irrespective of the type of hepatitis C they have, or even if they've already got cirrhosis, we can see eradication of the virus in greater than 98% of individuals. This is even more striking when you consider that when we take marginalized populations, socially disadvantaged populations, that efficacy is still around 90%. And this is virtually unheard of in any other discipline in medicine. I've put on the page there the faces of 2 individuals from Australia and New Zealand who are absolutely pivotal in developing the oral treatment regimes we now take for granted. This first individual, John McHutchinson, who I had the pleasure of working with at Duke in North Carolina, was pivotal in doing many of the original trials showing effective hepatitis C treatments could eliminate the virus. And then he went on to Gilead, who was the company who successfully developed the very first successful oral regime. Professor Ed Gain from Auckland, who I've also worked with in the past, is an outstanding clinician who published the very first trial that showed that a tablet-only regime could be this effective in treating hepatitis C. Whilst the treatment is very effective and Tasmania has very good uptake of treatment shown here, we could still do better. And at least on a national basis, half the individuals with hepatitis C who could be treated are not being treated. And it is important for us to identify those individuals, as this data shows us that even when you have no significant fibrosis, you have a risk over many years or even decades for, in over 50% of cases, developing significant liver injury silently that then can progress to those disastrous complications of cirrhosis, then leading to liver cancer or liver failure. So this has led to the recognition that we need to have non-invasive relatively cheap, well-tolerated and rapid methods to assess for the development of those individuals who may be at risk of progression of liver injury. And the way we do this is by looking for the presence of fibrosis. This is done best by the machine that's schematically shown here, which is known as a FibroScan. And this measures something called transient elastography. And what this relies upon is a ultrasound or modified ultrasound probe delivering ultrasound into the liver through the rib, the space between the ribs. And that reflection back from the liver tells us how stiff the liver is, and that directly correlates with the degree of fibrosis. We were very fortunate on my arrival here in Launceston 3 years ago to have the Clifford Craig Foundation fund the purchase of one of these machines. This enables us to now screen populations to see who already has some fibrosis and clearly needs to have a prioritization of treatment moving forward, a truly exceptional technology. But it does require some specialist interpretation. One of the things we've noticed is that the data derived either really tells you you are normal or tells you have cirrhosis, but the interpretation of the data in between those two readings is often problematic, and it does require some education and realization of some of the things that can alter the reading. So like everything in medicine, there are nuances associated with this test. We may just have to restart my talk. I'm sorry about that. Yeah. So what I wanted to talk about now was precision medicine. So one of the areas that you heard about in the introduction I've been involved in is understanding genetic variability in liver disease. But liver disease is no different to any other disease we now commonly face in our community. A lot of this data was derived from us understanding genetic differences in human cancer and now in a range of diseases. What I'm showing you here is what is commonly known as a heat map or a contour map of common genetic variations seen in many malignancies, including liver cancer. What you can see is great heterogeneity here. And this is the point I wanted to get across with this slide, is that most diseases that we lump together as representing a common etiological basis or common causative basis actually are a collection of a number of rarer diseases that each individual is manifesting in a different way. Liver disease has been one example where this has been studied very extensively, and pivotal work again done by Australians based overseas with John McHutchinson, who I introduced earlier, as well as at Westmead Hospital, showed that some genetic mutations were associated with very varied treatment and outcome responses in hepatitis C. The new treatments have overtaken that data, but we are now left with a framework that we can apply to other aspects of liver disease. And doctors such as myself now have to be able to understand data such as this. This is where we look at not hundreds of genes, not thousands, but tens of millions of genetic variants in a single sample. And with certainty of greater than 1 in a billion, have to pick abnormalities that then predict disease severity. And this is an example of a mutation that predicts your likelihood of developing liver cancer. I would be remiss if I didn't point out some of the current research we're doing, and this is a group I'm working with at St Vincent's Hospital and the University of Melbourne. And this group and us are looking at the development of another precision medicine approach where we take liver samples from either diseased livers or liver cancer and grow up miniature livers in a tissue dish, either representing the cancer or the injury, and can subject them outside of the patient to potential therapies or look at their response to therapies. And in this example here, we're showing the potential for these tumoroids or organoids, as they're known, these miniature ex vivo liver tissues examples, how they may be killed by, for instance, tumor infiltrating white blood cells. And this is very important for us to be able to predict whether patients may have a good response to something such as immunotherapy or are better suited to other therapy options. Now, we need all these treatments, non-invasive assessments and precision medicine approaches because there is a significant burden of liver disease we face. I've already alluded to the commonest cause of liver disease, which on a global basis is probably hepatitis B, followed by hepatitis C, alcohol, or metabolic syndrome, different to other metabolic diseases, or fatty liver disease coming fourth on a global basis. In Australia, we'll turn that around, and probably fatty liver disease is the leading cause. Other causes of liver disease you may be aware of, such as autoimmune disease, Wilson's, hemochromatosis, cholestatic disease, are relatively uncommon compared to these top four. What we do know is that liver disease is more likely to afflict men than women, with the death rate increasing steadily with increasing age. And this is important because a lot of the peak of disease we see is outside that range of what we would normally classify as adult productivity after the age of 65, and often also precludes other options which I've been involved in the past, such as liver transplantation, which typically only happens up to about the age of 70. On a global basis, liver disease is a major cause of human suffering and death. In 2000, cirrhosis was the 13th commonest cause of death and the 20th leading cause of cancer-related death. However, now cirrhosis is in developing countries the 9th cause of human mortality, and the 16th cause, and liver cancer is the 16th leading cause of death and mortality, and the 2nd leading cause of cancer deaths. In fact, in this graph here, which shows the age standardized death rates for females on the y-axis and males on the x-axis, we can see that liver cirrhosis has equivalent mortality to things such as road injury, malaria, falls, and HIV, which comes as a great surprise to many people who did not realize that liver cirrhosis was such a prevalent cause of mortality. When the WHO publishes its regular data on leading causes of death, cirrhosis of the liver and liver cancer both feature in the leading causes of mortality. If you put both of these together, because remember, cirrhosis of the liver can really lead, in most cases, to liver cancer, you can see that the diseases of the liver surpass many other common conditions that we associate as leading causes of morbidity and mortality. This rather confusing slide, though, shows the shifting burden of disease we're facing, particularly in the developed worlds. What this green shows is the absolute prevalence over time of cirrhosis due to fatty liver disease. What these progressive boxes are showing are increasing socioeconomic status, or going from lower socioeconomic countries or developing countries into what we would classically call developed or countries such as Australia. What we're seeing here is that the fatty liver disease is increasing in its prevalence to become the dominant form of liver disease seen within those populations, overtaking viral hepatitis B and other causes. This is no more strikingly shown than in this data here, which is from Canada. And we would agree it's a very similar jurisdiction to our own. What it is showing is that there is a progressive increase in the rate of fatty liver disease, such that it is going to be the dominant form of liver disease in Canada by 2040, and that all other causes of liver disease here have either a plateauing or diminishing incidence moving forward. Australia is very similar to other developed countries in its prevalence of fatty liver disease. In fact, we exceed in Australia the rates seen in Canada and are more equivalent to the United States. One of the things shown here in the pie graphs is that there is an example here where precision medicine may assist us moving forward in understanding the risk for fatty liver disease. And this is a polymorphism, very catchily known as the PNPLA3 polymorphism, that increases your risk of developing fatty liver disease. And Australians are instrumental in developing tests looking at this polymorphism, which should see clinical practice in the next decade. But patients within a context such as consulting rooms I run here, or the clinics I run in the hospital, do not present with a single potential cause of liver disease. And this is very important for us to factor into our management of these individuals. In a developing country, an individual may have a single insult leading to cirrhosis. But in Australia, they often present, they may have a viral infection, be diabetic, overweight, and drink alcohol. They don't have a cumulative increased risk of cirrhosis. In other words, if you have 4 risk factors, you don't have 4 times the risk. It's actually an exponential increase. When you have 4 risk factors, you have over 260-fold increased risk of developing the complications of cirrhosis, such as liver cancer. And this is very relevant, not just on a global basis, but also to Australia. This is premature deaths shown here. And we can see that in that age when we're meant to be most productive in society, there's a significant number of increased deaths, mainly in men, but also in women. When we look at the registry data, looking at the incidence of cirrhosis, men are shown in the top line and women in the bottom. Unlike most diseases we're seeing a steady progressive increase in the burden of disease we're seeing within our community. When we look at insurance data, it's well recognised that both liver cancer and liver disease are very leading causes of death within our community and basis for insurance claims. And that if we look in that, again, that age when we're said to be most productive to our society, that liver disease ranks 6 as a top 10 cause of death. When we look at those complications from the liver cirrhosis, the development of liver cancer, Australia's overall incidence is not high when compared to other jurisdictions such as China or parts of Africa. But what we are seeing is a dramatic increase in the overall incidence of liver cancer in this top line in men and in this bottom line in women. And this is data from the New South Wales Cancer Registry. What we do appreciate also is when we look at the top 20 cancers we encounter in our community, liver cancer and thyroid cancer, the only 2 cancers that are seeing a dramatic increase in overall incidence and worse overall survival, whereas every other major cancer we have encountered has seen significant improvements in patient outcomes. And there are a number of reasons for that, not the least of which is increasing recognition of the importance of the disease, increased uptake of surveillance, and much more extensive diagnosis being made of those individuals afflicted, but also it represents the increased burden of disease. Now I'd like to move on and talk about the aspects of this that we really do need to do better. Liver disease is one of those things that's attached with a lot of stigmatization. There's also a lack of recognition of the importance of liver disease or liver health in our community. Very few people worry about their liver, even think about it, or discuss it with their doctor. Very few people have a regular liver function test, and even if they did, would have a great deal of difficulty understanding the significance of the readings. There is a misconception commonplace in our community that cirrhosis is only due to alcohol consumption. This stigmatizes people who have this condition, who think this way, even if they themselves know that they don't have cirrhosis due to alcohol and do not seek medical attention. People erroneously think the liver can make urine and that you can survive without your liver and it's a non-essential organ. I can tell you now that the liver is a very essential organ, and the world record for taking a liver out of somebody and them staying alive is approximately 40 hours. After 40 hours, you cannot live without the liver, despite every other potential effort we can undertake. Oh, I meant to highlight here that liver cirrhosis is third only behind mental illness and obesity in terms of the level of stigmatization felt in the community towards this condition. This is important because we understand with stigmatization that patients or people with liver disease who should be seeking therapy withdraw from engagement, withdraw from seeking medical advice, fail to realize potential as productive members of society, and therefore have either delayed uptake of care or no care at all, often present with late illness, which requires more expensive and less effective care being administered, and overall the cost to the community, both in terms of lost productivity, engagement, and financial, is much more considerable moving forward. Hepatitis C treatment uptake is one example where we can do a lot better. I've already told you we have these highly effective therapies that can target hepatitis C. However, getting them to the populations that need the treatment is now the major barrier. The Australian government and the state jurisdictions have cooperated greatly, and Australia was one of the first places in the world to have virtually unrestricted prescribing for these new agents. It was something we should be very proud of, that our PBAC and PBS system that oversees medication prescribing virtually imposed no restrictions on prescribing when these agents became available. And you can see from this graph when that was in 2016. I tell the story about some of my colleagues who waited till midnight to do the first lot of prescribing of these medications, and in the next 8 or 9 hours to the early hours of the morning had prescribed over 200 or 300 courses of these drugs to patients who were eagerly awaiting treatment. We do not know how much it is costing the government exactly, but we do know that the PBS item codes for treatment list each treatment course at, if bought privately, at between $45,000 and $55,000. This is expensive treatment, and the government was very successful in negotiating a cap on treatment with the companies, totaling approximately $1 billion a year, a very successful treatment strategy. But what has happened over time is we are now seeing that the uptake of treatment within all the jurisdictions, despite telling you that upwards of 50% of individuals are still on treatment, is dropping away significantly. Tasmania is included in this data, and like all other state jurisdictions, we are seeing a progressive decline in treatment uptake. And it is now a federal and state priority to see increased hepatitis C prescribing. But it's not the fact that we're unwilling to do so as prescribers, it's the fact that the patients do not engage or come to treatment. And the answer to the problem can be seen, I think, in this slide. This reflects the pattern of prescribing we see for hepatitis C treatment. We can see here that when the treatments first became available, it was specialists such as myself who were doing the majority of prescribing. However, what we've noticed over time is we're now sharing this prescribing with more general practitioners and nursing practitioners. And I think this represents the fact that the focus of care here is shifting in towards the more marginalised population who feel stigmatised and do not want to present to a specialist rooms or hospital setting. And we now need to be going into the community to more actively pursue treatment uptake in those people who are infected. What we're aiming to do here is change the cascade of care we're seeing with hepatitis C. We know that we have significant burden of individuals living with hepatitis C, and that we have diagnosed many of them and can show that they're confirmed to not only have been infected, but importantly have ongoing chronic infection and are in need of treatment. The great discrepancy here is from this group who we know are infected and currently viremic to this group here who are receiving therapy. Because we know that once they have received therapy, greater than 94% of those individuals will be successfully treated for hepatitis C. So this is where we need to do significantly better, and it requires a rethink in how we apportion services for management of hepatitis C to much more be present in clinic settings outside of classic specialist rooms or hospital clinics. Another area we need to do better, and one of my areas of research interest, is in liver cancer, prevalence and uptake of therapies. In Australia, we see a variation in liver cancer services where we know that you can, in the very best centres now within Tasmania, mainland metropolitan centres such as Melbourne and Sydney, can see very excellent outcomes from liver cancer. However, if you move into more remote areas of Australia, we have outcomes from liver cancer that are equivalent to third world countries. And this is shown here, where the red represents a very high prevalence of disease in those communities, which is undertreated with very poor outcomes. In Tasmania, lots of the state is actually classified as disadvantaged or at either a moderate or high level. And this is shown in the colours on the graph here. And only really the developed areas around Launceston, Hobart and Devonport are well serviced with treatment options for liver cancer. I would argue, having arrived in Tasmania 3 years ago and been treating people here over those 3 years, that there's an unrecognised burden of disease, particularly within these lower socioeconomic areas shown, particularly in the north of the state. And one of the reasons we need to do better with the earlier diagnosis and recognition of disease is that patients with cirrhosis have often very poor outcomes. And in fact, it was recognised long ago that patients, when they get to the point of presenting with frank liver disease, often have outcomes worse than patients with advanced malignancy. Further, unlike cancer services, and I'm now not talking about liver cancer, I'm talking about liver cirrhosis, although those patients often develop liver cancer, we don't have the same support services that, say, a cancer clinic would have. And options such as transplantation are limited to the extremely unwell, the very sickest of individuals. And in Australia, we only do approximately 240 to 280 liver transplants a year. And there is this assertion, which is very true, that you can be too well for a transplant, but really too sick to do anything else effective during your life. And this is the problem we face that can be addressed by better recognising and earlier treatment of liver disease. And why are liver disease outcomes so poor? It's because the patients are often unrecognised, even at a general practitioner level. This is a silent disease that has to be actively screened for. Patients feel stigmatised, as I said, and are therefore isolated. The populations often afflicted can be immigrant populations, lower socioeconomic populations, and have very poor health literacy. Socially disadvantaged individuals are more likely to get liver disease and more likely not to recognise it or present for care. Patients as a whole with liver disease are less likely to engage in medical care. And we have less resources, as I've already highlighted, including less nursing support, and we are in desperate need of better support from addiction and substance abuse managers. Liver disease outcome in Australia is predicted to have an increasing burden of disease. Deloitte Access Economics estimates between at least $4 to $5 billion a year is spent in Australia alone on managing liver cancer, which, as I've already shown you, is poorly managed. There's estimated to probably be an equivalent amount of money being poured into managing chronic liver disease, such that the health burden overall from liver disease is measured in possibly as much as $10 billion a year. We know that in Australia, we're seeing this increasing burden of disease where recent modelling has shown from 2005 to 2030, we're going to see a 68% increase in the burden of fatty liver disease within our community. And that this is going to be more prevalent in populations that will do worse from this disease. In particular, we know that the complication of fatty liver disease through cirrhosis or directly through to liver cancer means that those individuals who develop liver cancer, who are in remote areas, will have twice the overall incidence and are less likely to have an early diagnosis. We know that if your socioeconomic status is lower, that you have over twice the overall mortality from liver cancer, which is potentially curable. One of the things we do know that potentially curative therapies for liver cancer are across the country only offered to roughly 20 to 25% of individuals who could potentially receive that curative option. And we know that if you're in a socioeconomically disadvantaged group or you're remote, that you're half as likely to get that option. Now, one of the things we also know, and in the public health arena, many liver researchers have done some very active modelling to see what we have to do to impact the burden of disease, is that sometimes some measures are not enough. And this is a very nice study that came out of the United States, looking at what would have to be done to impact the prevalence and consequence of alcohol-related liver disease. The first upper example shows the cases of cirrhosis attributable to alcohol-related liver disease. The bottom looks at the rate of developing liver failure or liver cancer associated to that alcohol-related liver disease and cirrhosis. It then looks at if you maintain current levels of alcohol, you have what's called a moderate intervention or what's called a strong intervention, and the effect on the events or deaths associated to this with both of these groups, meaning cirrhosis in these top two panels and the complications of liver failure or cancer in the bottom two panels. What it's showing here with a moderate intervention, which is simply looking at reverting alcohol consumption from the date of publication, which was in 2020, to that seen in America 2 decades ago at the turn of the century, you will see approximately only an 8% reduction in overall rates of cirrhosis and an even smaller reduction in the rate of complications. To see a significant turnaround in the overall burden of disease, where it's actually actively diminishing with time, you need a strong intervention. And in this case, it was said to be a 3.5% annual reduction in rate of alcohol consumption to impact the burden of disease significantly, such that by 2040 you could see approximately a 30% reduction in the overall disease incidence. So this goes to the concept that is not unique to this aspect of liver disease or other diseases in particular, that when we do interventions, they have to be of sufficient magnitude or impact to be able to significantly impact the burden of disease as shown here. The final area we can do much better is in our Aboriginal peoples. In people of Aboriginal descent or Torres Strait Islanders, liver disease is much more common. Hepatitis B is much more common, and they're more likely to have an aggressive form of hepatitis B. Hepatitis C is also much more common, as is obesity and diabetes. Aboriginal and Torres Strait Islander people are much more likely to be remote and are, as we know, significantly and adversely affected by socioeconomic inequality, homelessness, disproportionate rates of incarceration, reduced health literacy and education, gross stigmatisation, and have a embedded distrust of hospital-based services. In Aboriginal peoples, the rate of liver cancer is higher than the rest of our community, and it is the third and fifth leading cause of cancer death in men and women of Aboriginal descent, respectively. Overall, in remote communities, there is almost 6 times increased incidence of liver cancer, reflecting that in some populations, in men in particular around the age of 50, in Indigenous communities, hepatitis B and hepatitis B associated liver cancer are leading causes of death. This is partly reflected by the fact that the surveillance and recognition of disease is so poor in these communities, with surveillance which is undertaken in urban centres is rarely undertaken in these communities, is only seen in at best 15% of cases. This is such that if you're an Aboriginal person diagnosed with liver cancer, your median survival from that point of diagnosis is approximately 2 months. And this is a fairly appalling outcome, I think we'd all agree. I want to finish with a little bit of a positive note. I believe that we're heading now towards adopting better models of care for managing liver cancer. And this can be applied to all aspects of medicine, where we're now looking at personalised care. This is where patients have control over the way their care is planned and delivered. It involves shared decision-making, self-support management, education, what we call social prescribing, where prescribing moves out into the community and where patients have many more choices about the treatments they can undertake. And this leads to the development of something called a personalised health budget, where we now apportion the community risk, personal wishes of the patient, and then together develop the best treatment for each individual as they present for management. So on that note, I'd like to conclude and say that we've seen many advances in liver disease management, diagnosis, and we are looking at precision medicine approaches moving forward. We have a significant burden of liver disease to address and the changing burden of liver disease in Australia. However, we can do better. There are marginalised, socioeconomic disadvantaged groups and remote people do much worse with liver disease and liver cancer. And our Aboriginal peoples and Torres Strait Islanders do among the very worst in our community from outcomes from both liver disease and liver cancer. So I'd like to say thank you very much for the opportunity to present today. I'm sorry for the slight technical hiccup, and again, unfortunately couldn't be there with you in person. So thank you.
Now, we do have time for some questions. Professor Shackel is happy to answer some questions, and you should be able to see what questions there are from the online audience.
All right. So I'll answer both of those. The drug-induced liver injury prescribing medicine over the counter, paracetamol, kosh and the like? Yeah, it's a very good question. It is a standard question that I ask people when they attend clinic about over-the-counter, herbal, alternate, and importantly also weightlifting supplements are another great example. I've appeared on the ABC and national radio about these. We, every year here in Lonnie, and when I was in the metropolitan Sydney, would see cases of fulminant liver injury attributable to over-the-counter medications, particularly herbal medications, and also particularly weightlifting supplements are a very common unrecognised cause of liver injury. Paracetamol is one of those agents that is both appropriately and inappropriately vilified as a cause of liver injury. Where it is a very nasty cause of liver injury is in a both intentional and unintentional overdose setting. It's why in certain jurisdictions such as the United Kingdom, they banned being able to buy paracetamol in quantities greater than, I think it was 10 tablets per box, because that's about the level where an overdose starts to become potentially life-threatening. Unfortunately, in Australia, you can still buy 100 tablets. You just have to ask the pharmacist. They'll hand you a box. But the over-the-counter preparation is 10. It is quite safe, though, paracetamol at the right dose, and it's a very effective pain reliever. I now, as often as not, get asked, can patients take paracetamol even in cirrhosis? And the answer is yes, but there is a very definite level of safe dosing. And that safe dosing is up to 4 tablets in a 24-hour period, no more. But that has been shown to be very safe in even cirrhosis. In excess, however, paracetamol, in particular the combination with alcohol, can be particularly toxic. And the other thing, of course, I've already highlighted is the importance of recognising herbal remedies and over-the-counter things that are other unregulated foodstuffs. And the other ones I would highlight here that are often not paid attention to, but particularly need to be in our immigrant populations, are Chinese herbal remedies, as well as the use of green tea. Green tea, again, is something that's generally fairly safe in small quantities, but I've seen at least 3 cases of fatal liver failure attributable to that, and other herbal remedies. The final thing to highlight is because of the role of the organ in detoxifying many of the things we ingest, it is often the first site of drug-induced liver injury, and therefore it's one of the things that I see commonly is patients on polyprescribing, having many medications with drug interactions and drug toxicity, leading to us having to stop their medications moving forward. So a very important aspect of liver disease management that was commented on. So thank you for that question. The second question there is relating to this idea that we need to regulate our dietary intake and stop unnecessary calorie consumption. I don't disagree with that. I think that the model of care that I would suggest we're moving towards in this regard to addressing our dietary excess is simply like we do now with cigarettes, is making food cost what it should in terms of managing its complications. In other words, if you want to eat an unhealthy food, it will have an embedded cost attached to it that predicts its future impact, if you like, on healthcare. So that would then change the whole structure of the way food is priced in our community, and therefore we would, as all of us do, buy cheaper food and eat healthier. The other thing is we need to change the way we derive food and the level of processing of food, and encourage much more homegrown or fresh produce, as if I'm sure you're all aware that the diet that is now proposed and demonstrated in liver disease and most diseases to be the ideal diet is the Mediterranean diet. with minimization of red meat, more white meat, greater diversity of calories, increased fresh fruit and vegetables. And I think that's where we're going to have to move going forward. How much green tea is a problem? A couple of cases I'm thinking of were quite excessive. Green tea of 3-4 cups a day is probably quite safe. I remember one lady who was using it as a surrogate for weight loss and drinking litres of it a day, and she did develop liver failure from it. I also think she was taking a unregulated imported version of green tea, and that was the problem in that case. So like everything, moderation is the key. And so I wouldn't like to vilify green tea. I think in moderation, it's not something I personally drink, but my partner, for instance, does, and she just limits it to a couple of cups a day.
So the audience here at Inveresk, the meeting room, the museum, please raise your hand, and Malcolm will come around with the boom microphone so that Professor Shackel can hear your question.
You remarked upon 2 insults to the liver, one being hepatitis, which you spoke at length on research that was eliminating that insult as an intervention. And the other was alcohol, and one can, of course, eliminate that insult too by intervention.
Yep.
Go further down the chain. The insult has happened, or as is possibly the case with the diet one, people won't modify their behaviour terribly much, and you'll keep having the insults happen no matter what you try to do, except maybe for the hepatitis C one. So what go further down the causal chain to the effects? And you have fibrosis, you have sort of mild cirrhosis, then you have more dramatic elimination of functional liver cells. Is there research that you're aware of and can talk to us about intervening to somehow or other not just stabilize but reverse fibrosis, or, you know, and how successful is that?
Okay, so absolutely there is. So I'll go through the best treatment in that situation. Now we're now talking about fatty liver disease, is lifestyle modification. So you're about to hear the standard spiel that patients pay me money to hear in my rooms. So the very first thing to do is to acknowledge the importance of weight loss and exercise and a healthy diet. I recommend routinely to every single patient virtually the Mediterranean diet, and it's the diet of preference in this situation. It has those good aspects of a widespread range of foodstuffs, minimization of red meat, minimization of calories, and a lot of fresh fruit and vegetable and fiber. It is well recognized to be the best with regards to excuse me, diets that will have minimal impact on developing insulin resistance, and that's the cornerstone of many of the changes that are seen with fatty liver disease. Exercise is the next thing to address, but it has to be done with weight loss. You could only do this study in Japan, but it was done in Japan. They lined up a whole lot of Japanese individuals, and they said, we're going to make a matrix of this is how long you've got to exercise, and this is the duration you've got to exercise. And they determined very effectively that the amount of exercise you have to do to have a reproducible impact doesn't mean you can't do less and not get an impact. But this is what you have to do to get a reproducible impact, is you have to exercise at least 4 times a week, and each duration of exercise needs to be of at least moderate severity, of at least 40 minutes duration. And that comes as a bit of a shock to most people I see, as they either don't exercise quite that long or they don't exercise quite that frequently. Recent data also suggests that if you're able to maintain the 10,000 steps a day walking every day, that is also equivalent as the level of exercise. But that needs to be combined with weight loss. And that weight loss needs to be at least a 7% reduction in body weight in 1 year, sustained and ongoing. So again, this is data that said, well, if you want to take an individual and give them a goal to where they can achieve something that is in the majority of cases going to demonstrate a benefit, it's a 7% weight reduction in the first year of losing weight. That has to remain off and then be ongoing weight reduction to a healthy BMI. That's lifestyle modification. And I preface this in the rooms and in clinic when I talk to patients by saying it's very easy for me to say, it's very difficult to do, which then leads on to the next aspect is pharmacotherapy. And we all know what the pharmacotherapy is. They're called GLP-1 receptor agonists. And the one that is in the news all the time is called Ozempic. And it does work in this condition as well. Now, we've got to have a big caveat put out there that it is very effective at weight reduction and diabetic control, but it has not yet been demonstrated to be associated with significant reversal of fibrosis grade. And that is probably a reflection of the fact that we need years to demonstrate that efficacy. But I unconditionally support in those patients who are eligible, who are unable through the lifestyle modification to use these GLP-1 receptor agonists to have the weight loss and better diabetic control. All other agents here, and there are a range of drugs called PPAR receptor antagonists and the like, are not good. There's vitamin D. They can all be used, but they are very poor substitutes for what I've just talked about, a range of side effects and limited efficacy. The final thing I do recommend and had in the past, but we're moving more towards use of these GLP-1 receptor agonists, is things like weight reduction and obesity surgery, things such as the gastric sleeve or bands. Now, they're not without complications, and as a gastroenterologist, I see those complications. But when done in a metabolic and obesity service with appropriate pre-surgery and post-surgery counselling and involvement of dietitians, they can be highly effective as well. And this all comes back to identifying those individuals at risk. We know that just the BMI and the diabetes, hypertension, and all those things confers an increased risk. But what we also now know is if you have fatty liver disease, that's an even stronger predictor of risk moving forward than hypertension or cholesterol for your risk of stroke. And then if you develop cirrhosis, then your risk of dying from liver cirrhosis or liver cancer. So those other tests I showed you, the FibroScan for assessing fibrosis risk, become critically important in then segregating out from those group of individuals who's at particular risk of progression. One of the things I didn't highlight is the FibroScan is also very effective at picking up fat in the liver. So we get a steatosis score when we do the fibrosis score as well, meaning we can measure the amount of fat. But really, it comes down to, one, we can now assess these individuals and stratify their risk. We know their risk moving forward. We know the lifestyle interventions they need to undertake. We now also know the next therapeutic step. With all these things used effectively, we can, in the majority of individuals, I believe, stop the progression of fibrosis to cirrhosis. But when you're talking about millions of people in Australia with this condition, screening them, treating them, and avoiding the complications becomes a huge burden on our healthcare system, and one we're not yet appropriately addressing.
There's much work to be done. There's not much work to be done. Next question over here, I think. Is that right?
Okay, so that was pretty similar to what I was going to ask, but good luck with the lifestyle interventions, because that's pretty hard generally. I mean, we all know that we should lose weight and exercise more, but compliance is a real issue. A couple of things I was just wondering, like, is there a connection with heart disease? And the ketogenic diet I've seen it both as a risk factor and as a potential treatment. Do you have a view?
Yeah, look, the heart disease one is a very good question. I think I alluded to that in the last answer, but I'll state it again. Fatty liver disease is a marker for heart disease, risk of stroke. In fact, there was very good data that showed that if you have fatty liver disease, but do not develop fibrosis or cirrhosis, you still have a dramatically increased risk of dying from heart disease or stroke. So it becomes a surrogate marker for that risk, even if you don't develop liver disease from it. So that's a very important thing to show. What was the second part of the question? The
ketogenic diet.
Oh, the ketogenic diet. Yes. Look, intermittent fasting is very effective at improving insulin sensitivity. I certainly think it has to be intermittent and controlled. I, for instance, do it. My own personal habit is that I have dinner and I don't eat anything till midday the following day. That's generally been shown in a number of studies to be highly effective. This idea that breakfast is the most important meal of the day has been extensively debunked. In fact, there was a New England Journal paper which basically said, the Germans did this study, said that basically, yep, you can very well do without breakfast and have a very healthy lifestyle. The other intermittent fasting diet that is effective is the 2-5 diet. For those of you not aware, this involves 2 days of calorie restriction down to 800 calories a day, and the other 5 days of the week are uncalorie restricted. That's also been shown to be effective. It's like all things, moderation is a key and consistency is a key. The only way I can tolerate what I do as a ketogenic fasting is because I drink black coffee and that has no calories in it. But for instance, if you have milk in your coffee and you have to have a coffee in the morning, it doesn't work. You've got to have 0 calories to justify. And what we think happens, and the data is still not 100% on this, I must say, but what we think happens is that period of relative ketosis, and it's minor, resets your trigger for insulin secretion and keeps your insulin sensitivity appropriate. That is really one of the cornerstones of the development of fatty liver disease, is that it's an insulin sensitive organ, and the deposition of fat follows your insulin resistance.
Thank you. I think we've got time for a couple of more questions. I'm scanning the audience at the moment. Thank you.
I'm having a second bite of the cherry in the absence of other hands rushing into the air. There was a little bit of a flurry in the press some time ago, years ago indeed, crudely speaking, growing liver cells in a dish, and this was going to be a source of a new liver rather than hoping people tick a box when they cark it in a car accident.
Yeah. No, look, the ex vivo culture of liver cells, or xenografts, is the other thing that was topical. For instance, pig livers or sheep livers has been extensively investigated. There are a number of major hurdles to the adoption of that. We have very active immune systems, even if we think we don't. That mean that, for instance, a foreign species material is almost immediately rejected by our immune system, and even organs grown ex vivo from other people suffer from dysregulated epitopes, and these are the antigens the immune system sees, such that they aren't regulated. One of the reasons we tolerate transplanted livers so well at the time of transplant from another individual is basically we get a huge elimination phase when the graft goes in, where a lot of the immune cells that recognize it as foreign are almost exhausted by the sheer bulk of the organ transplanted. For want of a simpler way of putting it, it's clearly much more complicated than that. But that is a process that we see when we acutely put grafts in it. It's one of the reasons when I used to do the liver transplant job, we wouldn't actually worry too much in the very first 12 or 24 hours about immunosuppression, because we knew this process was happening in the liver, and then we would aggressively suppress the immune system to try and stop any residual immune response rejecting the liver. The other aspect to your question is those organoids I showed you are barely visible under a microscope, and they take us days to weeks to develop and extremely technically difficult to store and then revive from culture. To expand something from literally the size of the head of a needle to an organ that weighs 1.5 kilograms is certainly well beyond any technology we have at present. There is an exciting technology under development which uses decellularized scaffolds that will be populated potentially with cells quite rapidly. And it is quite amazing technology. The Italians, interestingly, have pioneered, where they've taken pig livers or human livers that were otherwise discarded at transplant, stripped them of all cells, and left simply the architecture of the liver there. And that, strangely, in a culture setting, is rapidly repopulated with liver cells. And that is more likely in the future, I think, to offer promise for people with liver failure for replacing the liver. One of the reasons these approaches are needed is, unfortunately, I don't know if you're all aware of the legend of Prometheus, but Prometheus stole fire and was struck down by Zeus to have his liver gorged upon by an eagle every evening. And the legend goes that this suffering was constant because his liver would regenerate, and the liver does in a normal individual regenerate. It's why if you have a motor vehicle accident and you're otherwise healthy, your liver can be lacerated and 2/3 of it gone, and within a week or two it regenerates. But what happens in liver failure or cirrhosis or liver cancer is, for whatever reason, the architecture that it regenerates on is so damaged that process doesn't happen, which is why I've commented on this Italian pioneered method of giving a preserved liver structure to grow cells on as being of promise in the future. But right now, what we need for organ transplantation is people to simply say they're donors. You can't take it with you. We need to be organ donors, and there is a very strong move in our society, which is getting a lot of contentious discussion going about opting for the Spanish system of opt-in and opt-out. Basically, if you opt in to be a donor, that's the default, and you have to actually opt out. In Australia, it's the other way around. And I can see the validity of the argument, and we need to have more discussion around organ donation to make sure that we're all aware of what that means. There seems to be misconceptions in our community that organ donation is you're less likely to get aggressive care. I would argue exactly the opposite, that if you have a loved one and you have any question about the care and you're being offered organ donation to see whether they would be a donor, they are getting the best possible care, because the level of care has just doubled or even tripled because they've been assessed by that many people to become a potential organ donor. This idea that somehow magically you keep them on life support and they'll wake up again is, it never happens. The cases that have been published are either just out lies or misrepresentations of another truth. And therefore, I think, I make an impassioned plea to everybody, be an organ donor. That's the best impact we can have now to helping people with otherwise incurable liver failure and liver cancer.
It raises questions of social policy as well as health policy in Australia, and of course within this state of Tasmania, and education policy. All three are needed, as well as medical intervention and research to progress this area of understanding and medical health in the population. And I think, Professor, you'd agree that there are many avenues there. It's a multifaceted thing.
Oh, absolutely, yeah.
But it needs to be coordinated and it needs to be pursued.
Absolutely. And as a society, I think stigmatization, organ donation, all these uncomfortable discussions unfortunately need to happen in domains such as the Royal Society.
And that's all we have time for today. And we welcome this chance to discuss and to share. And we very much appreciate your contribution to our program this year.